Good evening, everyone, and especially the esteemed faculty and audience. And I'm thrilled to welcome you all to this meeting called Pulmonology Forum. So, Pulmonology Forum is a meeting which is conducted by GSK in collaboration with the Indian Chess Society. I would wholeheartedly like to welcome and thank the Indian Chess Society for collaborating with GSK, especially Dr. Amita Nene, who is the TEI for ICS and who has also taken great efforts for this meeting. Also, I would like to thank Dr. Sandeep Salvi, who is the president of ICS, and also Dr. Rajadhar, who is the secretary for ICS. So this exciting event brings together leading experts like pulmonologists, radiologists, and healthcare professionals, and industry partners like GSK to foster collaboration and knowledge exchange in the vital field of lung health. So the Indian Chess Society, as we all know, is a renowned organization which is dedicated to respiratory health in India. And together, we aim to basically shine a light on latest advancements in pulmonary diagnosis, treatment, and patient care, and ultimately improve patient outcomes. So I would also like to mention that there is a short poll. There'll be two small poll questions for you, which have only yes and no answers. And these are basically just a feedback, which will be initially a pre-poll, and after the webinar, there'll be a post poll. And it's just a short survey just to understand the clinical practice and how better we can do clinical practice for patient outcomes. And at the end of the webinar, you will also get a feedback survey, which we will have to fill. So just to introduce Dr. Amita Nene, who will be moderating the event today. So she's the HOD of Respiratory Medicine at Bombay Hospital, Mumbai. So she's the program in charge and teacher in DNB Respiratory Medicine and MD and DNB Examiner for Pulmonology. She was awarded Legend in Pulmonology by the Union Minister Dr. Jitendra Singh in July 2023. She's an author of more than 50 publications and 12 chapters in pulmonary textbooks. She's the Honorary Secretary of the Indian Association of Bronchology. She's also the West Zone Chairperson of Thoracic Endoscopic Society of India, and also a governing body member of the Indian Chess Society. Last but not the least, she is the recipient of the Young Achiever Award in the field of pulmonology. So basically, our first speaker for the day is Dr. Bhavin Jankharia. He will be speaking in a very interesting topic of imaging in large airway diseases. So Dr. Jankharia is a partner and consultant at Picture This by Jankharia. Then he's an author of 5 books, 41 chapters, 76 articles, 36 posters in international journals and congresses. He has more than 1,500 invited lectures over the past 30 years of his enormous career. He's the past editor-in-chief of the Indian Journal of Radiology and Imaging. He has his latest book published on computed tomography of interstitial lung disease. And he's also the past president of the Indian Association of Radiology, Imaging and Association. So this talk is going to be very exciting from Dr. Jankharia. So we will start with this talk first. Okay, Abhijit.
Hi, welcome to this lecture on imaging in large airway diseases. The focus really is going to be on COPD and bronchiectasis today. You can see the disclaimer here, and we'll start off with emphysema. And this is then divided into the patterns that we see in smokers and then in non-smokers. We usually see 3 patterns of emphysema morphologically. We have centrilobular, paraseptal, and panlobular. Panlobular is quite uncommon in our country, so I'm going to really just focus on centrilobular and paraseptal. When we look at centrilobular emphysema, we have these different grades or stages of CLE that we can appreciate on a CT. A trace centrilobular emphysema is when the lucency, which is next to the vessel, involves less than 0.5% of any one zone. And this really implies very, very subtle disease. But when we see centrilobular lucencies, as we can appreciate here, involving more than 0.5% and less than 5% of any zone, we call it mild. When these centrilobular lucencies involve greater than 5% of a zone, we call it moderate. When we see the centrilobular lucencies becoming confluent, as we see here, then we call it confluent centrilobular emphysema. And then when there is a little more destruction, the confluence reaches a level where there seems to be an increase in the volume of the area involved, then we call it advanced destructive emphysema. We can have different grades in the same patient. So the severest form at any level defines the label that we are going to give the patient and say whether it's advanced destructive or confluent or moderate, etc. The same is true of paraseptal emphysema, where we have mild and substantial, and this depends upon the thickness of the paraseptal cysts. So if the thickness is less than a centimeter, then we call it mild. Here you can see that the thickness is greater than a centimeter, so it's substantial. You can see that not only is the paraseptal, there's also confluent centrilobular emphysema. Though most of this seems moderate, you can see the areas of confluence in a couple of segments, and that's enough to say that we have a combination of substantial and confluent centrilobular emphysema. So I can put all of this together in a single slide to get a better understanding of what mild, moderate, confluent, advanced destructive centrilobular emphysema looks like, and then mild and substantial paraseptal emphysema. We can quantify, and there is a lot of research happening currently. We still are not aware of how this will pan out in the clinical realm, but this is one such situation. This patient has moderate centrilobular emphysema, and then one such software has shown us 43% air trapping and 3% fixed lucency. The eventual aim using any of these techniques to estimate the extent of emphysema and air trapping is to correlate with the gold stages so as to get more functional information from the CT scans and perhaps even identify specific phenotypes that can then have specific forms of treatment and management. So as the management evolves into more subcategorization and specific forms of treatment, so also will the role of CT scan imaging quantification evolve to serve those needs. Now, when we talk about smokers and COPD, we don't just get emphysema in isolation. And so the same patient, for example, here has confluent centrilobular and paraseptal emphysema, also has these ill-defined centrilobular nodules of respiratory bronchiolitis, has those associated with traction bronchiectasis. So we say that there's RB with fibrosis, has reticular opacities, which we are labeling smoking-related interstitial fibrosis. In the lower lobes has airway expansion with fibrosis. And this combination of emphysema and AEF, or interstitial lung disease, could be labeled as combined pulmonary fibrosis and emphysema. And in fact, every patient who presents with emphysema, and you can see advanced destructive emphysema here, should be examined on CT for interstitial lung disease and vice versa. So here you have a fibrosing ILD, which there is a little bit of airway expansion fibrosis. The rest is smoking-related interstitial fibrosis, and the combination is CPFE. And we also have more guidelines that came out a year ago that put this in better perspective. But let's look at never smokers as well. And so the same patterns described in smokers may occur in never smokers often have different patterns. For example, this 46-year-old lady with a long-standing history of wheeze and mild breathlessness, and you can see this inspiratory-expiratory pair. There is overinflation here. There's a lot of fibrosis posteriorly. You can see volume loss posteriorly in the posterior segments of the upper lobes and the superior segments of the lower lobes, with more compensatory overinflation in the non-dependent segments. And there's extensive air trapping as part of the small airways disease, which my colleague Khushboo is going to cover in a subsequent lecture. On the coronal images, these are only inspiratory. We can see the extent of overinflation, diaphragmatic flattening, and the upper lobe fibrosis, which is post-infectious as well. So what this patient has are multiple findings: post-infectious fibrosis due to old TB, areas of constrictive bronchiolitis and small airways disease, some showing tubular bronchiectasis and areas of overinflation. Clinically, the patient had COPD. So these are findings of COPD in never smokers. And we must remember that 50% of all COPD worldwide is due to non-tobacco causes. And the poorer the country, the more is the non-smoking component. Women share a higher burden than men. And these are the various causes of COPD in never smokers. Now, why is this relevant for radiologists? I mean, for pulmonologists and physicians, these are obvious things. But for radiologists who read CT scans, we must remember that in countries like India, COPD is not uncommon in non-smokers. And when we are reading these scans, it is important to report the presence of air trapping and associated bronchial changes, including bronchiectasis, in detail. And it is a good idea for physicians and pulmonologists, and if you're listening to this lecture, to work with the radiologists and to make sure that they understand what is expected of them when they're reading scans of never smokers COPDs. And again, this is another patient. This is the same patient where we did quantification and found 44% air trapping and 7% fixed hyperlucencies. But we still don't know what to do with this information, but hopefully we'll have more to go with in the future. We then move on to bronchiectasis, which is irreversible, localized, or diffuse bronchial dilatation. From a radiology perspective, the questions to be answered are about the diagnosis, the etiology, and associated small airways. The small airways part, my colleague will be covering. The signs are these, and I'll explain them in a little more detail. Bronchiectasis, please understand, is one of the simplest and easiest radiology diagnoses to make on CT scans. Now, normally the bronchus is smaller than the accompanying artery, and you always see the bronchus and the artery hand in hand. When the bronchus is larger than the artery, now whether you use the outer airway or the inner airway, it doesn't really matter. Nobody actually measures this in real life or in clinical practice. We just eyeball it. So when the bronchus is larger than the artery, we call it bronchiectasis. And here's the signet ring when we see the bronchus and the artery separately aligned like this. When bronchi or bronchioles divide, the daughter bronchioles are always smaller and they taper. When they don't, as we see here, then that means there's bronchiectasis or bronchiolectasis. Typically, we don't see bronchioles in the last 1 to 2 centimeters of the lungs. If we do, then that again means there's bronchiectasis or bronchiolectasis. We also have additional signs, and they are listed here. Wall thickening is, again, eyeballed. We don't measure it. Typically, the normal bronchi have very thin, just perceptible walls. And the moment you see something that is more than perceptible, then that's wall thickening. Mucoid impaction is diagnosed when we see two white structures next to each other. So here, for example, you see the white artery and then another white structure, and that should immediately tell us that there's mucoid impaction in an adjacent dilated bronchus. And when we see tree and bud distally, that means there's associated inflammatory or infectious bronchiolitis. There are other forms of bronchiectasis, such as traction bronchiectasis, which is an important component of fibrosing interstitial lung disease, and parasecretional bronchiectasis that typically occurs following infections like tuberculosis. And so if you want to put all of this together in a single slide, you have the primary signs at the top where you have the airway to artery ratio greater than 1. And to repeat, it doesn't matter whether you use the outer or the inner, and no one actually measures in practice. Visibility of peripheral airways, lack of tapering, and then you have all of these secondary signs at the bottom. The next job that we have as radiologists is to find the etiology if possible. And here is the list of the common etiologies that we see in practice. Raja and his colleagues came out with this paper in 2019, just pre-COVID. And you can see that in India, 1/3 of all patients are post-tuberculous, and then you have the rest of them here. But this is one patient where it's relatively easy to make the diagnosis because there's dextrocardia and mid and lower zone bronchiectasis and inflammatory bronchiolitis. This is primary ciliary dyskinesia, and this patient has a subvariant which we know is called Cartagener's syndrome. The other condition that presents with asthma clinically, and this kind of a radiology appearance where we have proximal central bronchiectasis, is allergic bronchopulmonary aspergillosis. The pathognomonic sign is the presence of these high attenuation mucus plugs within the dilated bronchi. These can be focal to begin with, but if the disease is not kept under control and keeps progressing, then it would tell us that, and then you would see it to be bilateral and more extensive, as we see in this patient. So on the radiograph itself, we can identify the gloved finger and the VY-shaped opacities. And then in one segment, in the anterior segment of the upper lobe, we're seeing a large high attenuation mucus plug obstructing this bronchus with post-obstructive changes. This is a 60-year-old man with long-standing asthma, recurrent infections. You see the patient having significant bronchiectasis, but if you look at the trachea and the main bronchi, you see this diverticular formation, and this is typical of Meunier-Kuhn. Sometimes we can even make a diagnosis of other conditions, as in this patient with mucoid expectoration, 15 years old, with cystic bronchiectasis, and then there's pancreatic atrophy and fat infiltration, telling us that this patient has cystic fibrosis. Small airways disease will be covered in much greater detail by Khushboo. I'd like to spend a minute on technique. All of these diagnoses that I've talked about, all of the findings that I have described, are only possible when the CT scan images are of optimal quality. This is the scanning technique. We need volume supine inspiratory 1 millimeter or thinner slices at 0.5 millimeter intervals or better. Every patient needs to have an expiratory scan at the first instance. And if we're dealing with interstitial lung diseases, then we also need a volume prone image. If there is no ILD, then we don't need a prone study. But it is important to have an inspiratory volume scan and then an expiratory scan. The inspiratory scan obtained at end inspiration in suspended respiration. And it is important that you work with your radiologist to make sure that this can be done. I have done a series of 12 lectures sometime in late 2023.
Yes, thank you, Dr. Jankharia, for this amazing talk. It was so informative, and the way you explained about imaging in COPD and bronchiectasis I'm pretty sure it is going to help everyone in the audience and all of us listening a great deal. So now, after knowing about and hearing about imaging in large airway diseases, now we can delve into basically imaging and HRCT in small airway diseases. So this talk will be done by Dr. Khushboo Pilania. So I will just introduce Dr. Khushboo Pilania. So Dr. Khushboo Pilania is a consultant radiologist and founder at Eisen Imaging and Intervention. She is the author of various textbooks and a chapter including radiology of bone tumors in textbooks of orthopedics, the locomotor system, in textbooks of imaging and critical care medicine, in encyclopedia of radiology, imaging of finger and hand, inflammatory myopathy, and many others. So she has over 40 national and international publications and poster presentations in national and international conferences as well. She has been invited as a faculty at multiple, more than 200 national and international conferences over the last 10 years. So Dr. Khushboo, I would like to invite you and share your views on imaging in small airway diseases and HRCT in small airway diseases. Over to you, Dr. Khushboo.
Thank you, Dr. Hardik, for that. I think I am unable to share my screen. That's an issue. Just let me, for that kind, just let me check if. Is my screen visible? Can you see the PowerPoint?
No, ma'am. If you see on the right side, there'll be entire screen. If you just click on entire screen, you will have to just click on the box which is there.
Is this fine now?
Yeah, we can see your screen.
Yeah.
Yes, ma'am.
Yeah.
Thank you. Thank you, ma'am. Over to you.
So thank you, Dr. Hardik, for that kind introduction. And it's a great pleasure and honor to be a part of this meeting. Thank you, Dr. Nene, for having me here and to talk about imaging in small airways disease. It's always a tough task to speak on an HRCT after Dr. Bhavin Jankharia. Let's see how we go ahead with what we have about small airways. So I have no disclaimers. And we talk about HRCT in small airways disease. It is about how to image, which Dr. Bhavin Jankharia has beautifully explained and has stressed upon, but it can never be stressed on less. That imaging is as important as is interpretation. So we will go ahead about talking how to image and how to interpret. When we talk about the definition, so what is a small airways disease? Obviously, it is a disease involving the small airways. What are the small airways? These are the bronchioles. These are the part of the terminal part of the airways that do not have any cartilage or gland. They are by definition less than or equal to 2 millimeters. And if I talk about the radiology definition, we refer to them as that part of the airway which, if normal, is not seen. So if you see these small airways, that means it is disease. That is how the HRCT definition of the small airways goes. So it is something in the peripheral 1 centimeter of the lung, and usually you do not see any airways there. Now, when you talk about how the various diseases involve the small airways, the small airways disease can be primarily a small airways problem, that is primarily a bronchiolar disease, which involves the constrictive bronchiolitis, the acute bronchiolitis, panbronchiolitis, respiratory bronchiolitis, mineral airway disease, follicular bronchiolitis. So anywhere where the pathology starts within the bronchioles, it is the primary bronchiolar disease. However, the bronchioles can also be involved by a pathology arising from outside them. So when there is a lung parenchymal issue involving the bronchioles, or there is an interstitial issue involving the bronchioles, or any other systemic issue involving the bronchioles, like we see with hypersensitivity pneumonitis, where there is primarily a hypersensitive reaction involving the interstitium and secondarily the bronchioles in the airways. The RB-ILD, wherein the interstitium involvement has also occurred. The cryptogenic organizing in pneumonia, wherein the lung parenchymal affliction is there, leading to secondarily involvement of the bronchioles. And then other interstitial lung disease as well, like sarcoidosis, Langerhans cell histiocytosis. So now this is basically a etiological diagnosis. It does not have much relevance with respect to when we talk about the HRCT patterns. The HRCT patterns, or what you see on HRCT in a patient where the suspicion is of a small airways disease, depends upon not what is causing the affection of the bronchioles, but how is the pathology of the bronchioles happening. So the bronchioles can be involved in two patterns. Number one, either there is an obstruction of the bronchioles or there is inflammation of the bronchioles. So whatever be the underlying etiology, it leads to some specific pattern of insults on the bronchioles. Depending upon the pattern of insult on the bronchioles, we see various imaging findings. So if the external etiology has caused obstruction of bronchioles, then we talk about the nature of obstruction. The obstruction can be due to some intraluminal plugs, polyps, as happens in cases where the surrounding lung parenchyma is primarily involved. There is a consolidation in the lung which leads to formation of intraluminal polyps or plugs within the bronchioles, and we get a pattern which we call the organizing pneumonia pattern. The same pattern in the earlier days was called the BOOP, the bronchiolitis obliterans organizing pneumonia pattern. The second way of affection of bronchioles in which the bronchioles are obstructed is the constrictive bronchiolitis, wherein you have irreversible circumferential fibrosis as a result of some direct insult to the bronchioles, as occurs in cases of sequel of prior viral infections, etc. When you have such constriction of the bronchioles, it leads to regional air trapping and reduced perfusion, because in a segment of the lung, the air is not being ventilated properly because the bronchioles are diseased and constricted. And it leads to what we call the mosaic attenuation, the differential shades of the lung, one of the most important features of small airways diseases. Then we talk about the inflammation of the bronchioles, wherein it's not that the bronchioles are obliterated, the bronchioles are patent, but they are inflamed. So when they are inflamed, it will lead to thickening of the surrounding walls, and it will also lead to some intraluminal secretions. And how do we see them on a CT scan? So you start seeing the bronchioles. The bronchioles, which as far we've been discussing, if normal, are not seen, but then when their walls get thickened because of inflammation, they start being seen on the HRCT. And then the other thing that you see with these cases is the centrilobular nodules, the tree in bud pattern, wherein the terminal bronchioles or the terminal airways are plugged with the mucus. So this is the predominant pathology and the corresponding expected findings on the HRCT, which we'll be discussing. So primarily, these are the three patterns that you see on HRCT in a patient with small airways. So you see an organizing pneumonia pattern wherein there is obstruction of the bronchioles due to some plugs, which arise mostly due to some consolidation or lung parenchymal changes surrounding it. Then you have the regional air trapping or reduced perfusion in cases of constrictive bronchiolitis leading to a mosaic attenuation. And then you have the thickened airways or the centrilobular nodules, which occur in the cases of acute inflammatory bronchiolitis when the predominant pathology is inflammation. The mosaic attenuation or regional air trapping is one of the most confusing patterns in small airways, because to be able to elicit it, number one, is difficult. Number two, to be able to pick it and differentiate whether this is normal or abnormal is again difficult. Then to differentiate the various causes of mosaic attenuation is difficult. So for these reasons, it holds one of the, kind of star questions when you're talking about small airways disease. So first we'll talk about this. We said that mosaic attenuation is one of the important patterns in which an HRC, important patterns on HRCT for small airways disease. So when we talk of mosaic attenuation, we also need to know what is a normal lung attenuation. So normal lung attenuation, we mean that what is the shade of the lung of a normal lung on HRCT. There are various components which define the shade of the lung. What are these components? In the lung parenchyma, you have air, you have blood, and you have lung tissue. There are only three components. So all these three components together define the lung attenuation. A normal lung is a homogeneous black attenuation because the predominant component is air. And however, the attenuation of the lung depends also on the acquisition phase. So whether the acquisition is an inspiration or it is an expiration. The shade of the lung will change. Why? Because obviously the three components are air, blood, and lung tissue. Between inspiration and expiration, the quantum of air within the lung tissue changes. So the lung becomes more denser when the air is expelled out during expiration. Again, I cannot less reinforce this, that to be able to elicit all of this, an adequate HRCT technique is a mandate must. This has already been reinforced by Dr. Bhavin Jankharia, and we need to know that without this, none of the interpretation makes sense. So a good volume inspiratory scan followed by a volume expiratory scan is a mandate must in cases where airways disease is a question. Now we were talking about a normal lung attenuation. So this is a picture which we need to remember of a normal lung attenuation. A normal lung looks like this. The shade of the lung parenchyma is similar or just slightly more than the shade, black shade within the trachea. So this is how a normal lung should look like. It should be homogeneously black. This is how a lung looks like in inspiration. However, when we talk about expiration, the shade of the lung becomes more gray because, as we said, the air is expelled out. So in these cases, the shade will be grayer than that of the trachea, and this should not be misinterpreted as ground glass. Apart from that, we see a gravity dependent gradient. So black, white, 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 more white. So when you see such a homogeneous gradation, again, you know, it is not an abnormal ground glass, but it's the normal expiratory scan. And because of expiration, this gradient is seen. So we should be able to differentiate a lung which has been acquired in inspiration from a scan which has been acquired in expiration, because a lot of our interpretation depends on this. How do we differentiate? Very simple. In inspiration, the trachea is round. In expiration, the trachea becomes flattened from the back. So the first and foremost thing, when you start seeing a CT scan, look at the trachea, try to figure out that whether you are looking at an inspiratory or an expiratory scan. So let us look at these four examples and try to define for ourselves which is normal. So this is all black lung. The first thing I see that the trachea is round, so it's an inspiratory scan. Lung is black, homogeneous, paralleling with that of the trachea. It is normal. It is a more gray lung. I'm tempted to call it ground glass, but then I look at the trachea. It is flattened from the back, and I know it's an expiratory scan. And at the same time, I see a gradation. So this is again a normal expiratory scan. In this case, I see a lung which is slightly more gray than the trachea. Then I look at the trachea and I realize it's a good inspiratory scan. So this lung is abnormal. Similarly, in this case, there is no homogeneity, a lot of heterogeneity, and we know the lung is abnormal. So which of these is normal? Only A, AB, or ABC. And we realize that only A and B are normal. Why? This is an inspiratory scan. This is an expiratory scan where this ground glass is expected. Now we come to the topic mosaic attenuation. What is mosaic attenuation? Heterogeneity in the lung parenchyma, irrespective of whether it's in the inspiratory or the expiratory phases. If you see such heterogeneity, you know it is mosaic attenuation. That's a terminology with respect to CT scan. So the lung has mosaic attenuation, it does not define the underlying pathology. We have to figure out what is the cause of mosaic attenuation. There can be multiple causes of mosaic attenuation, because we realize that air is only one component of lung attenuation. So disease of air can cause mosaic attenuation, disease of blood can cause mosaic attenuation, disease of the lung interstitium can cause mosaic attenuation. So when there is differential air retention on expiratory scan, it causes air trapping, small airways diseases, and mosaic attenuation. When there is differential blood supply to different parts of the lung, again, it will lead to mosaic attenuation due to mosaic perfusion. This occurs in cases of pulmonary thromboembolism and also in long-standing small airways disease. Then differential infiltration of the lung tissue, as occurs with interstitial lung diseases. So let's look at these two scans. You have a good inspiratory scan, and then you think that it is all normal. So it's homogeneous lung, you don't see a pathology. The patient has come with some mild persistent cough which was not being treated. And you see the CT scan and you say it's normal. But when you do the expiratory scan, you see a lot of mosaic attenuation all over. And you realize it is not normal. This patient has a small airways disease which is elicited so well on the expiratory scan. Similarly, you have mosaic attenuation on the inspiratory scan, on the expiratory scan. Now, is this small airways disease? So that is what I was coming to. It is not just airways. In this case, the cause is pulmonary thromboembolism. It is due to differential perfusion. Again, inspiratory, expiratory, the mosaicism is more accentuated, but it was present on inspiratory also. In the inspiratory, there is a lot of ground glass. So we realize that there is some component of lung infiltration apart from the airways, and it is an interstitial lung disease, the way we see with hypersensitivity pneumonitis. So how do we differentiate between these causes of mosaic attenuation? If we follow a simple algorithm, life becomes much simple. So I see an HRCT and I see mosaic attenuation. It is easy to pick up mosaic attenuation. Simple when you see a heterogeneous lung parenchyma, it is mosaic attenuation. The first question you should ask yourself is whether it's an inspiratory or an expiratory scan. So you look at the scan and you realize the trachea is flattened. It's an expiratory scan. We go back and look at the inspiratory scan. If the inspiratory scan was normal, that means it's an airways disease. So for example, this was an expiratory scan with mosaic attenuation. The inspiratory scan is absolutely normal, and we know it's an airways disease. That is, there is differential air trapping. Now, if you look at the expiratory, if you see that the mosaic attenuation was on the expiratory scan, but on the inspiratory, the mosaicism persists, unlike the previous case where on the inspiratory it was normal. So if the mosaicism is seen on expiratory and it persisted on the inspiratory, the next thing you do is look at the caliber of the vessels in the black and the whiter areas. If the vessel caliber in both areas is normal, that means it's not due to differential perfusion. It means it is due to differential infiltration, as you see with hypersensitivity pneumonitis. So expiratory scan, air trapping. Inspiratory scan, again air trapping is persisting. So we rule out airways, only airways component. We see that the vessel caliber is almost more or less similar in the black areas and in the whiter areas. And so we know there is no differential perfusion and it is an infiltrative lung disease. The third case scenario is when the caliber of vessels is differential. So you have black areas with smaller vessels and white areas with larger vessels. And on the expiratory images, there was air trapping, which remained more or less similar or improved. Then it is a chronic pulmonary thromboembolism. If in a patient with differential blood vessel caliber on the expiratory images, the air trapping increases, then we call it due to airways component. We'll come to it. So let us look at this case, mosaic attenuation, an expiratory scan, inspiratory scan, more or less similar. The whiter areas have larger blood vessels, blacker areas have smaller blood vessels. That means the differential attenuation is due to differential perfusion, and it's a case of chronic pulmonary thromboembolism. The fourth case scenario wherein the differential perfusion and airways component are together. So for example, in this inspiratory scan, we are seeing some areas of air trapping which have accentuated, and in the blacker areas, we also see that the blood vessel is normal in caliber, is lesser in caliber. So airways disease is also associated with hyperperfusion, but the way we differentiate is, trying to relate to the fact that the air trapping accentuates on expiration. If it is accentuating, that means there is definitely an airways component. If air trapping remains, the mosaicism remains same between inspiration and expiration, that means it's predominantly a vascular component. So this is again the same example wherein it's an inspiratory scan and you see that the between the black and the white areas, the vessel caliber is same. Here the vessel caliber is more in the white areas, lesser in the black areas. Again, much more in the white areas and lesser in the blacker areas. This was on the inspiratory scan. So this is definitely due to abnormal lung. These two are due to abnormal perfusions. Now we do the expiratory scan and we realize that the air trapping increases much more in this case. So that means the reduced vessel was also due to air trapping. Whereas in this case, the air trapping remains more or less the same. So this was due to pulmonary thromboembolism. So the first case was hypersensitivity pneumonitis, constrictive bronchiolitis, and pulmonary thromboembolism. So this is the basic algorithm that you may use to try and differentiate the various causes of mosaic attenuation, to pick up the causes which are due to small airways and rule out causes of mosaic attenuation which are not due to the small airways disease. Mosaic attenuation in context of small airways disease occurs when the small airways involvement is of the form of constrictive bronchiolitis. Constrictive bronchiolitis occurs when there is an insult to the bronchioles leading to irreversible fibrosis, which occurs in cases like post-inflammatory or infectious bronchiolitis, post-toxic fume exposure, some connective tissue diseases, post-transplant due to some drugs, and also secondary to large airways involvement. So again, coming back to the where the small airways are involved, it can be a constrictive bronchiolitis, which is an obstructive airways disease which presents with mosaic attenuation. It can be an obstructive small airways involvement due to intrabronchiolar plugs, which leads to an organizing pneumonia pattern, or it can be a proliferative or inflammatory bronchiolitis where there is primary inflammation of the bronchial walls and not so much of obliteration, and so the bronchial walls start being seen. This is a very typical organizing pneumonia pattern wherein you see patches of consolidation surrounding the bronchioles. Then you have the pattern wherein you start seeing these smaller airways. So as we already discussed, that airways towards the peripheral 1 centimeter are usually not seen. When you start seeing these airways in the peripheral 1 centimeter, then you know they are diseased. So in this case, when you're seeing these airways towards the ends, these small dots, that means the smaller airways are involved. So that is when you start seeing the airways due to direct involvement. Then you talk about the proliferative bronchiolitis, which typically occurs like these tree and bud nodules. So these are the terminal bronchioles or the terminal airways which are plugged with mucus, or they are very much inflamed, that they appear as these typical tree and bud pattern, which is very typical of an inflammatory or infective bronchiolitis. So this is pan bronchiolitis, wherein all the bronchioles throughout the lung are involved. And another is the pattern where you see these ill-defined centrilobular nodules. Then you have the follicular bronchiolitis, respiratory bronchiolitis. All of them have a very similar pattern. So as I said towards the beginning, multiple etiologies lead to certain very specific pattern of involvement in the lung parenchyma in cases of small airways disease. Then sometimes the inflammation is not so much within the bronchioles but from outside the bronchioles, as occurs in cases of acute hypersensitivity pneumonitis leading to such ill-defined centrilobular nodules. One of the tricks to enhance the visualization of these tree and bud nodules, centrilobular nodules, is to use a 3 to 5 mm MIP images on the lung window. So this is again stressing on the fact that ask for the soft copy images. So this cannot be done unless you have the soft copy data sets. So once you have them, do these 3 to 5 mm MIP and these nodules will be seen very, very well. So just before winding up, one of the most important things is that both end inspiratory and end expiratory scans are a mandate must to be able to diagnose small airways disease. The acquisition should be an HRCT acquisition. Ask for soft copy images. Flattened trachea means expiratory image. The three main patterns of CT in small airways diseases, mosaic, attenuation. We need to differentiate the cause of mosaic attenuation. Mosaic attenuation is heterogeneity in the lung parenchyma, which can be due to heterogeneity in the air, heterogeneity in the vascular supply, or heterogeneity in the lung infiltration. We've discussed at length on how to differentiate one from other. When you look at tree and bud nodules, it means that you're looking at a proliferative bronchiolitis, or you may have an organizing pneumonia pattern. So that is all from my end. Thank you.
Thank you, Dr. Khushboo, for this amazing talk. So now, basically, we understood about imaging in large airway diseases, which was followed by small airway diseases from the radiologist perspective. And basically, in every patient that we treat, the most important thing is an MDT, a multidisciplinary team. That is what I feel. So, along with the radiologist, who better than one of the most renowned pulmonologists in India, which is Dr. Amita Nene and Dr. Nitin Abhyankar. So now we will get the pulmonologist perspective in imaging in airway diseases. So I will just invite Dr. Amita Nene to just speak and have a few words, and also introduce Dr. Nitin Abhyankar. Over to you, Dr. Nene.
Thank you, Dr. Hardik, for handing this over to me. And first of all, I would really want to congratulate Dr. Khushboo for the fantastic talk. I think, Khushboo, you were really very, very good. It was a brilliant talk covering everything that we wanted to hear. And of course, the talk by Dr. Bhavin Jankharia was also excellent. I would want to thank Dr. Hardik and Team GSK for this wonderful initiative, the academic initiative. This is something that we really want to learn. We pulmonologists really want to read our HRCT chest better. And of course, a wonderful initiative by Indian Chest Society, our president, Dr. Sandeep Salvi, and Dr. Rajadhara, secretary, for making sure that we are taking academics to the doorstep of every pulmonologist in the country. So with this brief introduction, I'd like to now invite my very dear friend, Dr. Nitin Abhyankar, who doesn't require any kind of introduction whatsoever. He's a brilliant pulmonologist. He's an excellent academician, and he is one of the best interventional pulmonologists we have in the country. He is practicing, he's doing IP since 20 years, and he's a course coordinator for respiratory therapy, Pune Hospital Research Center. And he's the vice president of Indian Association of Bronchology and founder director, school interventional pulmonology, just so many very things. But the bottom line is that Dr. Nitin Abhyankar is pride of our Maharashtra. With this small introduction, I'd like to introduce and welcome my dear friend, Dr. Nitin Abhyankar. Over to you, Nitin.
Am I audible?
Yes, sir. Yes, sir.
Yeah. I guess I was lost for a minute or so. So where are we? We can start with this presentation?
Yes, sir.
Yeah, excellent. See, I think Khushboo and Bhavin are one of the best CT radiologists in this country. And I think they have done a great job of confusing us clinicians no end. Let me tell you very frankly. So I think I'm trying to simplify it as best as I can, and then Amita and she'll be coming with her question. So whatever messages they were trying to give us, a few of the take homes are: COPD is essentially characterized by a progressive. Can I get my slide set back? Yeah, that's great. Can we go full screen if possible? Yeah. Okay, great. Thank you. The COPD is essentially characterized by a progressive worsening in the lung function because of the irreversible airway obstruction. This is either caused by a loss of the alveolar gas section units and the elasticity or the mucofibrotic remodeling. So multiple interplays of these three things which will happen. CT imaging using advanced X-rays and computers is possibly crucial in identifying and also phenotyping, if you want to use that word, or characterizing the large airway diseases. Firstly, confirming the COPD and then also indicating some kind of disease progression with the kind of tools that you have at your disposal. I don't think Bhavin or Khushboo have really referred to MRI as yet, but MRI in addition allows safe longitudinal imaging. That means you could collect more data while obviating the risks associated with ionizing radiation. So possibly MRI is the future tool, and I think we'll have their thoughts processes on this while we are at the discussion table. Chest radiography, I mean, that's what we have been doing for last so many decades, and most parts of the country can only afford that at this point in time. And a quality chest radiography, where will it really play a role? It will mainly play a role in, say, picking up a pneumothorax, kind of a complication, and rule out conditions which are mimicking symptoms of asthma. Spirometry, when we look at spirometry as of now, remains as an insensitive tool for early small airway changes. Of course, we have a disruptive technology like at this point in time, what we have is impulse oscillometry or airway oscillometry, and which has been changing the gameplay substantially. But at the same time, at this point in time, what we have with us is a better quality, better resolution HRCTs, and relatively less accessibility to iOS or impulse airway oscillometry, to be more broader in the term, because force oscillometry does exist. So with substantial disease presents before abnormal observations can be seen. So the whole idea is, if I have to really pick up a COPD on a spirometry, it will take me probably a decade by the time the smoker has smoked for 10 more years. And that might be the best message that can be there. So why do I want to diagnose it very early? Whether it is a disruptive technology like impulse oscillometry, or whether it is a standardized and improving technology like CT, or maybe even MRI eventually, and we'll have our radiologists talking about it. But the abnormality can be seen earlier if we use a more sensitive tool, and therefore I think spirometry cannot be the gold standard in the early disease at least. Of course, established disease, it still remains the gold standard. That's not a problem. Next slide, please. Can we have the next slide, please? Yeah, thank you. So once again, let me reiterate that chest X-ray is considered valuable in the initial evaluation of patients with a suspected small airway disease. It can reveal signs of air trapping. However, the chest X-ray findings are often fairly non-specific and may require further evaluation with advanced imaging modalities. And of course, we have spent a lot of time on HRCT. We might spend a little more time on the MRI in the discussion part of it. But HRCT is the imaging modality of choice for evaluating the small airway diseases, offering a very detailed visualization of the bronchial walls, bronchioles, and the surrounding lung parenchyma. Although less commonly used than CT, MRI can technically provide additional information in certain cases, particularly in pediatric patients or in individuals who are having a contraindication for using an HRCT or a CT imaging. So with that, I think I will hand it over to Dr. Amita, and thank you very much for your patient listening. Thanks.
Thank you, Dr. Nitin. It was a very, very precise and very concise, to the point presentation. Thank you so much. I'd like to now invite Dr. Khushboo also to join. Dr. Khushboo, can you please switch on your video?
Yes, ma'am.
Yeah. Okay, great. So we've had two fantastic talks by Dr. Khushboo and Dr. Nitin, and I'm very, very happy to now ask questions which we pulmonologists keep on facing. We have many, many questions from the audience also. So some of the questions I'll ask which I feel are important, and then we'll go to audience questions. So I'll come to Dr. Khushboo first. So Dr. Khushboo, can you tell me that how would HRCT chest help in differentiating us between various COPD phenotypes like emphysema, chronic bronchitis, etc. from the HRCT? Can you make out?
Definitely, we can. So when we try to differentiate the emphysema predominant versus airways predominant versus a mixed type, it is quite easy if the HRCT has been acquired properly, because the centrilobular emphysema, the panlobular emphysema, the paraseptal emphysema, they are evident as these cystic airways, airspace dilations, versus the chronic bronchitis, in which case we more often see the air trapping, which we've discussed. So if we've acquired the inspiratory expiratory sets and we see predominant air trapping, then we know we are dealing with an airways predominant COPD, wherein if we are seeing a lot of centrilobular emphysema, which will be evident on the inspiratory scans itself, then we know we are dealing with an emphysema predominant COPD.
Okay, fine. And about chronic bronchitis?
So for chronic bronchitis, most of the times the pattern that you see on a CT scan is the mosaicism or the air trapping. So if you do the inspiratory expiratory set and you see significant air trapping, then you know you are dealing with chronic bronchitis. When it is with respect to the smaller airways, when you are talking about the larger airways, then the various signs like the Tram-Tax signs, the signet ring signs, wherein the larger bronchioles are visible, will be visible to us.
Okay, I thought maybe chronic bronchitis, we might get peribronchial thickening.
That's it. So the bronchus becomes visible only when you see the peribronchial thickening. Otherwise, the bronchial walls are so thin that you do not see them on an HRCT. When the walls become thick, they are visible, and that's when we start calling them bronchiectasis. And the chronic bronchitis has both elements. Either you see the bronchi for themselves or you see the air trapping secondary to their involvement by constrictive bronchiolitis.
Wonderful. So I believe so this way emphysema is very, very easy to pick up on HRCT. And if it's chronic bronchitis, then requirement of expiratory scans
is a must.
Would be, yes, thank you. Yeah. I'd like to come to Dr. Nitin now. So Nitin, you did cover a part of it, but again, I want to ask that can you elaborate on the current methods for diagnosing COPD and the limitations of these methods?
Yeah, I think we have been using for COPD, very frankly, ordinary chest X-ray for most of the times. We do not really resort to a CT, but I think increasingly over the last decade or so, we are asking for a CT radiology also. I think the MRI is possibly in the future, and I think one of the radiologists can eventually elaborate on it. We have been using gold standard as spirometry. We are essentially looking at FE1 FEC ratio, which does not go beyond 0.7, and post bronchodilator reading remains more or less the same. There is no reversibility, or there is a partial reversibility at the best. And once in a while, of course, we have asthma COPD overlap, that is echo, but that's a rarity. So what we really look for the diagnosis COPD as a gold standard is a combination of chest X-ray, combine that with a spirometry, which shows me a fixed obstruction, plus minus a restriction, and a partial reversibility at the best. But if you really ask me, in the last 5 or 6 years, we clinicians are seeing a sea change in the terms of impulse oscillometry or airway oscillometry, if you want to call it that, and that is being changing the game dramatically, just as much as the HRCT has happened over the last decade, and MRI may happen over the next decade. That's what I can summarize that.
Yeah, wonderfully said. So I basically feel that clinical history is most important. So basically, a patient who's usually more than 40 years of age and is either a smoker or there is
As the
exposed to
typical
some
story.
kind of, yes,
Or is exposed to something noxious, of course. I mean, it has
exposed
to be
anything that
addressed.
is a trigger, nauseous chemicals, we know biomass, etc. This over and above with history of breathlessness, which is progressive, and cough, expectoration, etc. Over and above PFT and iOS would be probably very, very useful in probably diagnosing those COPD zero, as we say, in which the spirometry might be normal, but iOS might come abnormal, like we are seeing in HRCT, where we see expiratory scans, expiratory air trapping. So thank you, Nitin, for this answer. Great. I'd like to come to Dr. Khushboo now. So Dr. Khushboo, like based on the CT scan of a COPD patient, can you tell us if this is severe or not? Can you assess severity based on HRCT chest?
So, as was discussed by Dr. Bhavin Jankharia also, it's mild, moderate, severe. We can rate them on that basis the extent of percentage of the lung involvement. That's what we can do on an HRCT. We can definitely tell the extent of lung parenchymal involvement. So basic 5%, 10%, 20%, that is possible. But at the end of the day, the severity will be basis the clinical presentation. So, I mean, it can add as a supplement to the clinical presentation of the patient, wherein if clinically the patient has very severe disease, we can add on to it by saying that yes, the HRCT is also showing severe changes.
Wonderful. So I really liked what you said, that of course we come to know about parenchymal damage, but we also know about PFT. We know the gold standard, mild, moderate, severe, very severe, but PFT is always to be correlated clinico-radiologically. So the radiologically extra information would help that, FVC is probably low, not only because of air trapping, but also because of coexisting restriction, which might just be missed on a chest X-ray if it's involving the left lower lobe. So great. So now the same question for pulmonologists and radiologists both. I'll ask Dr. Khushboo first, then Nitin, I'll come to you. The same question. So basically looking at the HRCT, can we ever predict that this patient has a high chance of getting an acute exacerbation of COPD?
Not really. I mean, there aren't any such very specific telltale signs that will tell us. We can, yes, definitely tell that this patient has a severe disease, but to say that this is a patient who's heralding an acute exacerbation on an HRCT stuff.
Okay, wonderful. Nitin, what would you like to say?
Absolutely agree with the Khushboo on this. We are completely at a loss of predicting who is going to be in the hospital day after tomorrow, or even maybe to early morning tomorrow, despite having severe, very severe, all the categories in place, perfectly sorted out CT, perfectly sorted out lung functions, and we really don't know whether he's harboring that pseudomonas or not, whether he's going to exacerbate because of that or not, irrespective of whether he's harboring it or not. So I think the whole story remains unpredictable, and therefore I think that phenotype of frequent exacerbators is not classified either by radiology or by lung function. It is classified by the frequent exacerbations only.
Correct, absolutely. So if at all we do HRCT, and if we are lucky, if patient has a pneumonia which is coming up, or there's a small pneumothorax, something like that, then we might come to know that this could lead to any kind of exacerbation. But otherwise, just looking at the CT scan, we can't really decide about who could be the acute exacerbation types. Great. So I'd like to ask you, Dr. Khushboo, that I'm asking you all the questions which we pulmonologists might feel. That, for example, we have ACOS, which is, basically it's asthma COPD overlap syndrome. And the thing is that it's mainly a clinical diagnosis. But by any chance, looking at the CT scan, can you tell us, looking at the HRCT, that this could be combination of asthma with COPD?
No.
Can't, right? Perfect. Agreed. So Nitin, I want to come to you and ask you that basically for asthma diagnosis, would you rely on CT scan or you'll go mainly by history, etc.? What do you do?
I would look for history. In addition, for asthma, I must look for reversibility, because that's how we define asthma and that's how we differentiate asthma from COPD. But a single reading may not be enough. Because if somebody who's been badly managed for a long time, for example, an asthmatic who's been totally badly treated, no inhaled corticosteroids for good 10, 15 years. And the first lung function also may show me a very bad lung function with poor reversibility. But if I treat him with proper therapy, and another 3 months down the line, the whole story may change dramatically. Even for that same patient, the radiology may be dramatically abnormal to start with, but may normalize over a period of time. So I think the clinical story matters, the follow-up matters, and the trending of whatever you are doing eventually will matter most.
Absolutely. Very, very well, sir. I completely agree. I think now from COPD, let's just move a little bit to bronchiectasis. So, Dr. Khushboo, coming to you, we very well know that bronchiectasis is like most sensitively picked up on HRCT chest. And already Dr. Bhavin spoke about, all the wonderful signs that we have to diagnose bronchiectasis. So I would request you to just enumerate these once again. What on HRCT will help us diagnose bronchiectasis? And then please tell us if there's new technology in HRCT or any new things which over and above might help us to diagnose bronchiectasis even earlier than now.
So, talking about the various signs which help us diagnose bronchiectasis, the first thing is when we look at the bronchial artery, bronchus and the adjoining pulmonary artery ratio. The ratio should be more than 1. So, when the bronchi are bigger than the arteries, that means there is bronchiectasis. Usually, the bronchial diameter is same as that of the artery. That is 1. When you start seeing the bronchial walls as very prominent, that means there is some chronic or acute inflammation in the bronchial walls which has thickened them and you are seeing it. So that becomes bronchiectasis. The signet ring sign is in cross section when you see a large ring of the bronchus with a diamond of the artery studding on top of it. That's a signet ring sign. The tram track is when you see the bronchus going parallel to each other. Usually the normal anatomy is that the bronchus tapers, that from larger to smaller diameter, but when they are diseased, their ability to collapse becomes limited and you see 2 parallel moving tracks moving towards the periphery. When you start seeing these bronchus in the peripheral 1 centimeter of the lung, again it depicts that the bronchi are diseased and you are looking at bronchiolitis. So these are the various signs of bronchiolitis and bronchiectasis that you see. When you talk about if there is any advancement, the most phenomenal advancement over the last 10 years is the understanding of the fact how to acquire an HRCT. So everything has remained same, but the understanding of how to acquire HRCT has phenomenally changed. And that learning curve is the biggest advancement. Apart from that, yes, a lot of AI work is being done in trying to trace the bronchi towards the periphery. As yet, nothing has been FDA approved that they will help us pick up things before anything else. So they're all in the pipeline. So let's hope that something comes up to pick up these findings better than before.
Wonderful. I just feel I like the way you said that, how to do HRCT correctly is the best advancement we've had in recent times. And I'm just so happy that, Dr. Khushboo and Dr. Bhavin make it a point to, stress upon this in every meeting, whether it's radiology or pulmonology. So that's great. I would just like to add 2 more things about bronchiectasis that we were taught always, for diagnosis. Of course, we know about the ratio, but basically the thing is that if we see bronchi which are non-tapering, so non-tapering of bronchi is also diagnostic of bronchiectasis. And if you see bronchi in the lateral 1/3 pulmonary fields, you're not supposed to see them. But if you end up seeing bronchi in the lateral 1/3 lung fields, if you divide them into medial, central, and lateral, so if you see them, that also is suggestive of, rather diagnostic of bronchiectasis. So we need to remember these 3 things: the ratio, the non-tapering of bronchi, and seeing the bronchi in the lateral 1/3 of the lung fields. And of course, then we have the signet ring sign, etc. So there's an interesting question from the audience, Nitin, I'd like to ask you. There's Dr. Sonali from Lucknow. She's asking that you're suspecting bronchiectasis from history. Is there any particular reason when you might choose not to do a CT scan to confirm this?
Unless until, somebody is not able to perform a CT at all for whatever reason. I really don't see that. Very often I've undergone an MRI myself, and I know how scary that damn thing was. But at the same time, I think HRCT takes a few seconds, unless until you just don't fit into the CT, whatever that console is. You are that huge. I really see no contraindication for doing that. I don't think a contrast is a must in this kind of a scenario. So it's a good inspiratory, good expiratory, and in some situations, a prone positioning. So I think prone versus supine. So I would rather not look at a CT as some kind of a menacing technique, which I will avoid. Mostly no, mostly no. Very, very few exceptions.
Wonderful. So, Nitin, actually, I completely agree with you. I think I understand the question. Probably what she means is that if the history is very typical, you're seeing clubbing, and if the chest X-ray is already showing bronchiectasis, then probably you may not need to do. So I agree.
But all said and done, Amita, in
Yes.
that case also, if the
I
patient
think
is not affording, that's a different story. But if the patient can afford it or it can be done, I would love to know what is the extent, what kind of pattern, is it cystic more, is it cylindrical more, what is dominant pattern, is it, are there sums of secretions, all that information is so invaluable.
So yeah,
I'm sorry, I'm taking the next half a minute, but I'll try and add in culture identification of what is residing in that bronchi, those dilated bronchi, and is that going to be a damaging future for that patient. So I think that is worth knowing whether chronic bronchial infection is there.
No, correct. So no, I totally agree with Dr. Nitin. So the thing is that even if the patient's history and chest X-ray are obvious bronchiectasis, doing an HRCT will always add more information because we know X-ray is one-dimensional and left lower lobe is not well seen. So it's always good to know the extent of bronchiectasis in case if the patient has massive hemoptysis, etc. You know what you're really dealing with. So I agree with Dr. Nitin, and I think it was an interesting question. But in today's day and age, unless the patient is completely non-affording or is so obese that can't go into the CT console, like Dr. Nitin said, we should always get the HRCT done because sometimes HRCT might even tell us about the cause of bronchiectasis, which we are not coming to know from the history. So with this, I'd like to ask Dr. Khushboo the same question, that when you diagnose bronchiectasis from HRCT, do you think there are certain pointers which might contribute towards identifying the cause of bronchiectasis in this patient?
Yes, quite many times we have certain specific signs. Like, for example, one of the entities is the Meniere's disease, where you start seeing these bronchial diverticula, and then you know that yes, that is the underlying cause. Then you have ABPA, wherein if you see the high attenuation mucus sign, you know that the bronchiectasis and there is associated high attenuation mucus. Often, if you see that there is something obliterating proximally and you see the fluid bronchogram sign within, that is also helpful. So there are quite many cases wherein we can at least give a suspicion of the underlying etiology. If it's an active bronchiectasis versus it's a bronchiectasis which is a sequel of some prior insult, it's a traction bronchiectasis versus it's a inflammatory bronchiectasis. So those kind of details can be given on the CT scan.
Yeah, wonderfully said. Nitin, would you like to add anything more?
Yeah, I think more or less, yes. Very, very rarely, since she was referring to constrictive obliterative bronchiolitis, and we have one of them. We have a diffuse pan-bronchiolitis, we have one of them. But they have been identified only after a thoracoscopic lung biopsy was done. Very, very rarely we will need them. But most of the time, the clinical story and a very high quality radiological imaging, plus in addition, whenever cultures, when they are relevant. I think these three are good enough.
Yeah, wonderful. So now coming to Dr. Khushboo, you think there are any HRCT features which will help you differentiate between bronchiolitis and lower respiratory tract infection, not pneumonia? LRTI stroke bronchiolitis. Can you tell from HRCT?
I don't think that'll be more of a clinical call because to a radiologist, a lower respiratory tract infection can be seen as a bronchiolitis. So if it's an infective bronchiolitis, you're seeing centrilobular nodules towards the terminal bronchus. I cannot say for sure it is due to infection or due to inflammation if I don't have the clinical picture. So if I'm told that this patient is febrile and everything, then I know it's infection. If I know it's a smoker, then I would attribute it to bronchiolitis related to smoking.
Yeah, wonderful. So basically, I think again, over your history becomes very, very important. So great. Coming to Dr. Nitin, there's a nice question from Dr. Sakshi Batra. You know, she's a dear friend, pulmonologist, a very, very competent, great pulmonologist. So I think I'd like to ask this question to both. So Nitin, I'll ask you first. Dr. Sakshi is asking that she wants to know if sometimes it becomes difficult to differentiate between an upper lobe apical segment big cavity or a bulla when we see a post-TB sequelae patient who's also a smoker. In this case, how would you differentiate between the bulla and the cavity?
Very, very frankly, unless until, of course, I mean, Khushboo will add something to what I'm saying, but unless until I have a thick wall, something which is hinting me towards a cavity, and which is eventually have as thick walls, that is one way of differentiating. But once in a while, you can really get stumped, and particularly if one of those cavities has ruptured and then eventually has been absorbed, and then a thinner wall remains. It's sometimes really, really impossible to sort these out. But I think Khushboo can add something.
Yes,
Not really. I am also bowled out with that. But yes, the same thing that if you have a thick wall, the cavities are usually thick walled. You have a thick walled cavity, you have other stigmata of TB around or an infection around. Then it becomes more of a TB. If it's a thin walled or a cyst with an imperceptible wall, it becomes an emphysematous bulla. Usually to find a solitary emphysematous bulla is again rare. So you will see some signs of emphysema in the surrounding lung. So if you see those signs of emphysema with an emphysematous bulla appearing like structure, then you call it. Usually TB cavities are much thicker. So that is one of the most important signs, as Dr. Nitin sir also said.
Yeah, I totally agree with both Dr. Khushboo and Dr. Nitin. Basically, cavity becomes very, very important. The size, the thickness of the wall becomes very, very important. So basically, in bulla, by definition, is less than 1 millimeter. It's like a hair. It's 1 millimeter, and usually you cannot see all the walls of the bulla. So something is kind of suspicious over there. Where it's a question mark, and you imagine the wall might be going there. Cavity usually is very, very well defined. It's thick walled. But as Dr. Nitin, Khushboo both said, sometimes it gets difficult to distinguish. And then you look out for other changes of smoking, because bulla won't alone exist. You will have other emphysematous changes. But I basically feel that it was a very interesting question. We have one of the questions, Dr. Khushboo, for you. Dr. Samir is asking, are prone scans mandatory for all? So this is for all CT scans in particular, or for obstructive airway disease? Would you like to?
No, prone scans are not a mandate for all. Usually, they are a mandate for all cases where we are suspecting interstitial lung disease if a radiologist is not there on the board to look at the images and decide if a prone is needed or not. For airways disease specifically, prone can be easily omitted.
Absolutely, absolutely. Nitin, would you like to agree?
No, perfectly. Yeah, well said.
Okay. Nice, thanks. We have a very good question from Dr. Somnath Bhattacharya. Again, he's a friend. This is a difficult question, but a very good question. Maybe both can take. I'll ask Nitin first, or you all decide who wants to answer. Any correlation between pulmonary vascularity score with small airway disease documented by iOS or FOT?
Oh, I'm very happy living in the zone of iOS plus minus FOT. I mean, I've been using both the technologies and I'm very happy with them. But the radiological correlation between this and that, to my knowledge, not yet documented. Khushboo, if you know any paper which is doing that, but I think because this is an emerging and a very disruptive technology. It's particularly the iOS or FOT is taking the whole pulmonology world by storm, and a lot of people are interested in it. At the same time, we just don't have enough correlation between the radiology and this at this point in time. No, to my knowledge, no. Sorry.
No, sir. So none that we know of either for now.
Okay, we have many audience questions. I'll just quickly try to. We have a dear friend, Dr. Sudarshan Pothal, who's our ICS governing body. He's a West Zone chairperson, East Zone chairperson. So Dr. Sudarshan is asking, what are the indications of HRCT in COPD? So I think both would like to. Nitin, why don't you take this?
Yeah, I'll take this first. Very frankly, most of the times I would not do it in a mild, moderate kind of a thing, early disease. But if you really ask me, the best value comes in the early. So, somebody who is say obstructed to say 30% FEV1 percentage, and I know this man has smoked for 40 years and he is definitely a COPD. And I'm seeing enough on CT that I'm seeing enough air trapping. I really have no value addition by a CT. Whereas a smoker within the first 5 or 10 years of his life, smoking life, I would say, and if he's shown something really abnormal by a CT, that he's having air trapping, which is not shown on the spirometry. iOS, if suppose imagine that in your scenario is not available, it's not showing you the air trapping, it's not showing you the subtle obstruction. If it's something like a prism, but I'm able to document emphysema or document something more sinister, I can convince my patient better for A, quitting smoking, B, possibly taking medicines when they are relevant.
Okay, would you like to add anything, Dr. Khushboo?
No, ma'am, I can't agree more because indication always the pulmonologist will have to decide. We will
Correct.
scan the patient.
I totally agree with Dr. Nitin. I'd just like to add by saying that if we have a patient of COPD where you're doing everything correct, but if the patient is not getting better, if the breathlessness persists, or if he becomes a recurrent exacerbator, we keeps on getting either an exacerbation or recurrent infections, I would at that time do an HRCT to rule out any underlying bronchiectasis where we know that we have to take partial drainage really seriously, or you want to rule out something coexisting like a TB that you're not aware of, which X-ray is not picking up. So I totally agree with Dr. Nitin that normally HRCT we don't do in a clear-cut patient of COPD, but we definitely do if the patient is not doing well despite the correct therapy, or if the patient is getting recurrent infections. Okay, we have a good question from Dr. Ravindra. So he's asking, is there any role of AI, artificial intelligence, in constructing an absolute diagnosis or a most accurate diagnosis? I think maybe Dr. Khushboo should take this.
Yeah.
So as of now, none. But yes, AI is coming up big way. It is trying to, supersede a lot of things. A lot of places it has a big role. But the way we've realized AI works is that it can always be a help in quantification of a disease, that is describing mild, moderate, severe with more quantum numbers and more objective values rather than being a tool which can be used for diagnosis, because solitarily one modality can never diagnose. And a diagnosis can never be made only on an HRCT or only on a clinical ground. So only a merger of the two, which as yet AI is difficult. AI can just take up into one picture at a time. So that's where AI falls short.
So I believe currently we are better, right? Currently the
Absolutely.
knowledge of the radiologists, and I think that is currently, but I think AI is evolving.
AI
So
is evolving. AI is definitely
AI is
evolving, and
evolving dramatically. At the same
we
time,
the
let
question.
me repeat what has been repeated ad nauseum, that no artificial intelligence is worse than innate stupidity. So I think
Exactly.
clinical
I can't agree more. I can't agree more.
Yes.
So it can create blunders. I mean, if not, take not in the right hands, it can be blunderous.
Absolutely. Agreed. We have so many questions coming up. I'm just trying to take most of them. We have our dear friend Dr. Sushma Dukkad. I mean, she's a lovely friend of mine and she's a brilliant pulmonologist from Nashik. So Nitin, let me ask you her question. So Dr. Sushma is asking, there are some patients having more changes of bronchiectasis, but they don't have expectoration at all. The bronchiectasis sicca that we spoke to. But they are breathless. So Dr. Sushma is saying, but they are breathless. What is your line of management? I think it's a fantastic question that she's asked.
It's a great clinical question. And very frankly,
yes,
you have to focus on bronchodilators. No question about it. You will use a combination of LAMA and LABA, both possibly ultra LABA, if that is relevant in that particular patient, or a combination of dual, 2 doses in a day of a LAMA-LABA combination, whatever is more sensible for that patient. I might add even a theophylline before adding inhaled corticosteroids. Inhaled corticosteroids and a clear-cut bronchiectasis, I would be really wary, because you never know when the infection is going to get harbored into that. And in fact, one of my so-called dry bronchiectasis, which was dry for 15 years, lands up with a horrible Pseudomonas infection and was with us for 15 days on a ventilator. And then, I mean, we were like, wondering whether I made a mistake of adding inhaled steroids 2 years ago in a very, very tiny dose. And still we were cursing ourselves. So I think that question will always remain one in your mind, that whenever you are thinking of inhaled corticosteroids, be a little careful unless until you have documented, or you keep on documenting repeatedly, absence of a infection, which is there, chronic bronchial infection, then only you are justified in adding inhaled corticosteroids. I definitely would not go to oral corticosteroids in almost none of these situations.
So I agree with Dr. Nitin. I just want to add a little more about what I feel. I think doing a baseline PFT, a complete PFT is very, very important. And the thing is that once the PFT shows once the PFT shows obstruction, we want to basically start the patients based on amount of obstruction. We'll start with LABA, we'll add LAMA. And the thing is, if on LAMA and LABA, if the patient is still breathless, then I would actually do a PFT. And if it's showing reversibility on LAMA LABA, then I would be comfortable adding ICS, inhaled corticosteroids, because, in our TOPD webinar also, Nitin, as we know, that all the studies from abroad are saying that ICS give rise to pneumonias, but in India, we have not found this at all. So I basically feel that if, despite giving LAMA-LABA, if the PFT is still showing good reversibility, which is more than 12% and 200 ml in FEV1, then I would be quite happy to add ICS. That was number one. The second thing is that even if they have this
that's like a overlap scenario where there is an asthma coexistent with a bronchiectatic.
Actually, what happens is, with so much of biomass exposure everywhere, we really don't know that, what kind of irritation we are picking up. And other thing I would like to say was that even the patient has dry bronchiectasis, very often it happens that the secretions are so very thick that the patient is not able to really bring them out, and therefore there are no secretions. So I would definitely encourage these people to have lots of water. So hot water, 3 to 4 liters a day, because it has been found that once you hydrate these patients, the secretions become thin and they start coming out. And I would also either recommend postural drainage, or I would definitely recommend these devices, Aerobica, for example, or any of the one that you are comfortable with, because very often they do start bringing out secretions. So I think that though it's so-called dry, we must do this, and vaccinations we must, the flu shot and the pneumonias. I think this is something that we must do.
I think so well said, Amita. I think, we typically say that difficult to treat asthma versus genuine severe asthma. So is it true dry bronchiectasis or difficult to expectorate kind of bronchiectasis? So you have to sort out.
Absolutely. So Dr. Sushma, a very interesting question. Thank you, Dr. Sushma. I'd like to, Dr. Khushboo, I'll ask you now. Again, Dr. Prashant Kolte, a dear friend of ours. Khushboo, are you there?
Yes, ma'am.
Okay, I'm sorry. Yeah. So Dr. Prashant is asking, can we diagnose airway remodeling on HRCT to rule out in a case of asthma COPD overlap? So I think this is a wonderful question. So the thing is, I told you that very often we have this clinical diagnosis of asthma COPD overlap, where patients have symptoms of COPD and asthma both, and then you can't say which one is more. So you call it ACO, asthma COPD overlap. So it's a wonderful question that he's asking, that can we diagnose airway remodeling on HRCT?
I understand that from airway remodeling, we mean that the airway has been diseased, and it's an irreversible disease of the airways that we see with the airways predominant COPD subtype. So predominantly what we will be seeing will be something like bronchiectasis, that is the dilation of the bronchi. So obviously those things we can see on a CT scan. Any changes in the airways which are in the form of dilation of the airways, change in the caliber of the airways, change in the shape of the airways can all be picked up on an HRCT.
Yeah.
So normally in remodeling, we use this word, Khushboo, mainly for fixed asthma. Nitin, you want to say something?
Yeah, I think if you remember, Amita, I had shared a paper with you on the bronchial dilatation and the quantified bronchial dilatation. predicting the kind of responses, the number of infective exacerbations in COPD. So I think that I know it reminded me of that particular paper, which if you remember it.
Correct, yeah. So I think it's a very interesting question, but I think as of now, probably we can't, right, Khushboo?
No,
As of
Yes, ma'am. So if we are talking of a reversible airways remodeling, we can't.
no,
right.
I absolutely
So,
agree.
yeah, so again, I think Dr. Prashant asked a very important question that, about echo, whether we can diagnose echo as such on CT. I think it's more of a clinical diagnosis.
I would go clinical combined with spirometry volume, maybe add iOS to it, and in the end add CT, if at all, if I'm really clueless.
Wonderful. So we have again a very good question by Dr. Animesh Arya, open for both of you all, but I think we should ask Dr. Khushboo first, and even Nitin will be happier that way. It's a very hardcore radiology question, but it's extremely interesting. So thank you, Dr. Animesh, for this question. Khushboo, Dr. Animesh is asking, what is the difference between volume and incremental scan? And can you show an example, and if anything not done otherwise?
So, volume and incremental scan, the way they differ is like in a volume scan, the entire lung from the apex to base is scanned sequentially. So, the scanner moves like this, and the entire lung from apex to base is scanned in a contiguous manner. When you talk about incremental scan, it is the scanner moves tuck, 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 tuck. So there are intervening spaces which are missed. So those gaps are there, and you have sections taken at certain intervals. Earlier days, when we did not have the helical scanner, which moves like this, like a helical, uh, in those days, the incremental scan was done for HRCTs, which was done with 4 slice 8 slice conventional CT scanners. Nowadays, where 16 slice helical CT scan is the basic requirement almost everywhere. Almost all scans are helical, which are a volume scan acquisition.
Totally agree. Absolutely. I don't think, gone are the days when we're looking at, slices taken at, those, as she said, at intervals, and in between 10 millimeters were completely missed. I don't think that happens anymore.
Yeah, agreed completely. Very well said, Dr. Khushboo. We have again, I'm so happy everybody known to us is posting such lovely questions. So Dr. Swadeep Mishra, our dear friend, Khushboo, this question I would like to give you first, and Nitin can always add if he wants to. So Dr. Swadeep is asking, how useful are low-dose CT protocols for airway diseases compared to standard doses? Like, for example, tail lung, we do low dose. So he's asking that how useful are they for COPD, airway diseases, low dose CT protocol?
So they are comparable to a standard CT scan. Obviously, the diagnostic information that we obtain from a low dose is lesser than what we will obtain from a standard dose. But having said that, when we are doing a CT scan for airways disease specifically, we any which ways need an inspiratory and expiratory scan, which means exposing the patient twice to the radiation. Then, doing a low dose inspiration, low dose expiration is absolute no sense. It does not make a sense because we try to do a low dose scan, especially like in cancer patients, we said. Why? Because we know that we'll be scanning them very regularly, or we do it in patients as a screening tool because we know this patient does not need. But when we are doing it for an indication, there is no such benefit of a low dose scan.
Agreed. Very well said, and a very good question by Dr. Swadeep. Very, very good question. We have a very interesting question from Dr. Shweta from Delhi. Nitin, I'd like you to take it. Actually, the question is on hypersensitive pneumonitis, but because it involves the airways, let's just take it. So Nitin, this question is that how can HRCT findings help guide treatment decisions in hypersensitive pneumonitis?
Very frankly, if HRCT is suggestive of dominant ground glassing and that kind of a story, and the clinical story is very well matching with it, and you have a specific antigen in your mind, and okay, fine, this is say a bird fancier, typical bird fancier's lung. If you have that story and a good HRCT, that alone is good enough. So you don't even have to go to a bronchoalveolar lavage or a transbronchial lung biopsy or even a cryo lung biopsy, or any further invasive techniques are not necessary. If you are not sure about the antigen, and if you are not sure about the pattern, or more commonly what we encounter in clinical practice is a badly fibrotic HP, which looks like a UIP. Again, the CT falls short once in a while, and you can't differentiate because the dominant pattern is UIP like pattern. This can hold true for even a CTD ILD, but more true for HP because we are discussing HP right now. HP is sometimes HP UIP is so much overlapped that I have seen this, that even after a biopsy, even after a multidisciplinary discussion, it's not ruled out completely, because you see 2 or 3 granulomas and you can't really make sense of the whole story. Is that a burnt out HP? Is that a UIP? Is that a UIP with few fibrogenic, fibrogenic foci will be classical for HP, but a few granulomas which are ill-defined still present in that conundrum. Very, very tough to sort out. So I think once in a while you will come across a very confusing scenario, but for majority of your clinical decision making, the clinical story, radiological pattern, not necessarily only HRCT, even a plain CT can tell you that, but an HRCT gives you most of the clues. Is it cellular? Is it more likely cellular? Is it dominant ground glassing? Is there honeycombing or not? Is there upper lobe dominant or not? So all those patterns are in favor of an HP. And if you look at that, most of the times your decisions are going to be right.
Very well.
There is no absolute answer to this. I'm sure Khushboo will agree with this, that once in a while you still will be confused at the end of the story.
I fully agree with you. Very, very well said. So I basically want to just tell Dr. Shweta a very important question, because now HRCT classification has changed into fibrotic and non-fibrotic. So the thing is that fibrotic, non-fibrotic, we call it based on HRCT and pathological findings. So if a biopsy is now going to be done, then only based on HRCT, we're going to say whether fibrotic or non-fibrotic. And therefore, definitely, if we see a CT which is non-fibrotic, then we know definitely we have to give steroids and do antigen avoidance. And if there's a relapse, then you want to add a second drug like azoran or azathioprine or mycophenolate. And of course, if you see fibrotic, then you're not, just because there is honeycombing, you will not upfront start antifibrotics for these patients. You will treat them with steroids, with antigen avoidance. And despite treatment, if the patient still progresses in 2 out of 3, whether it is pulmonary, whether it's radiation or function, only then you'll start antifibrotics. So basically, I just feel that with HRCT, hypersensitive pneumonitis right now, we just know so much to treat HRCT, treat hypersensitive pneumonitis based on HRCT. So I think, again, a very interesting question. There are many, many questions. I'm first taking from people who I know. So we have a very good question from Dr. Gitanjali Panda, again, a dear friend of ours, a wonderful pulmonologist. Nitin, I'd like you to take this question. Dr. Gitanjali is asking, is there any role of NAC, N-acetylcysteine, in bronchiectasis cases having thick and viscid secretions?
I think it's $1 million question, and the frank answer to it is no. But at the same time, if you look at the data which is coming up related to NAC, the NAC data is really looking optimistic when it comes to exacerbations. So if you are really looking at just viscid sputum and something which you'll expect to irritate, I would rather go to Amita's suggestions of hydration. Even if you want to nebulize a bronchodilator, do that. Do a good postural drainage. Do everything before you put on NAC. But if you put somebody on NAC, the benefit may be in terms of exacerbations. And in a person who's exacerbating repeatedly, NAC may be valuable. That is the message in a nutshell.
Yeah, I totally agree with Dr. Nitin. Basically, the thing is, if our secretions are thick and viscid, then let's hydrate the patient, and let's basically make sure either we are doing postural drainage or using one of the devices to bring out secretions. However, despite that, if it doesn't help, then definitely we can give NAC, for a short period of time, and there's no harm in that. And if the patient feels better, if he continues, it's okay. But basically, hydration and postural drainage are most important in addition to vaccinations. So very, very good question. There's a question which is from Dr. Yogesh. He's asking if no iOS is possible. I think maybe Khushboo should take this because iOS is not there. So Khushboo, if the iOS, that is impulse oscillometry, is not possible, we normally use iOS to diagnose small airway disease, which is not very simple to diagnose with spirometry. So he's asking because iOS is not available everywhere. So it's a very good question. Dr. Yogesh is asking if iOS is not possible due to non-availability, then any role of CT scan to detect early COPD?
Yes, so that is what we've been discussing over time, that because we realize that there are limitations of spirometry and even the patient being so overtly symptomatic to make the clinical diagnosis upfront, CT scan does have a role. So these air trapping is something which is picked up pretty much early in the course of the disease when there is not so much of architectural distortion in the lung. Then very early mild emphysematous changes are also picked up before the patient really becomes symptomatic. So a lot of these things are picked up before the symptomatology even comes up. But
Okay,
we,
fine. Yeah. Okay, great. So one more question for Dr. Khushboo, then I'll come to Nitin. So Khushboo, this question you have answered partly, but this is very interesting. Dr. Shashki is asking, low dose of CT for CA lung screening. Are there any updates on it? Anything new is happening on the low dose CT for CA lung? Very interesting question.
So, yes, the newer thing that is happening is that the awareness has increased quite much, and people have realized that it's quite a phenomenal tool, especially because it detects lung cancer early. And at the same time, the treatment has advanced so much that if we are detecting the lung cancers early in the stage, they can be treated quite much well. So the updates are that yes, if the patient has a pack year history of smoking, he's above 50 years of age, then they fall into the category where they should go ahead and do a low dose screening of the lung to detect these nodules.
Okay, fine. Wonderful. Great. So this question we've already taken, but it's come again. So I'll just ask you, Nitin. So Dr. Vivek is asking, is there any role of HRCT in diagnosing asthma or deciding severity of asthma?
I mean, once again, I think Khushboo has been saying a lot of those things about it. Once in a while, you will have a asthmatic who is needing an HRCT to be documented to him. But if you really ask me, asthma is a symptomatic disease. Very few asthmatics are totally asymptomatic. And if I'm not having the sensation of obstruction, then I would use a more sensitive, either a spirometric evaluation or a residual volume evaluation, volumetric data, or an impulse oscillometry. I wouldn't jump to the idea of doing a HRCT as a primary tool in an asthmatic for sure. In a COPD scenario, yes, because it needs much more convincing. But asthma is a symptom-driven disease. But people are more symptomatic. People are symptomatic even with a normal spirometry, for that matter. So I think I would rather look at symptoms first, oscillometry if the spirometry is failing me second, and if I'm absolutely helpless, then only I'll look at HRCT as the tool to work.
Wonderful. I completely agree, Nitin. Very well said. So we have about 20 questions still pending, but I just want to take this question. I liked it very much. And it's already 10:20. So maybe this question I can ask to both and keep this as the last question. So it's a very interesting question. The question is from Dr. Sonali from Lucknow. She's asking, how do factors like age, smoking history, and occupational exposure influence the interpretation of HRCT findings in these diseases?
I think dramatically yes, because unless until, and this information should be fed from us to them. Very frankly, Khushboo, if she doesn't know anything about anything, how is she going to report the whole thing?
The question is history. Like
absolutely. So all three are important. All three are equally important. I don't think anything is less important or anything is more important.
No, Nitin, the question is slightly different. No, I completely agree with you. This history is very important. The question is not that. The question is that the presence of smoking, the patient of occupation exposure, and age, based on this, do the HRCT findings change?
I think Khushboo is the better person to answer this. I have no answer.
You said history is very, very important. Yes.
So the
Khushboo,
findings don't change, the interpretation changes.
we
So
want to
if,
know that. I think it's
so
very
if we are seeing these, if I'm seeing some cystic air spaces in the lung parenchyma, for example, I know the patient is a smoker. I will think of Langerhans cell histiocytosis. If I know the patient is not a smoker, then before labeling it as Langerhans cell histiocytosis, I'll think twice. Similarly, if I'm seeing some cystic air spaces towards the apices, I'm seeing some fibrosis towards the bases, I know the patient is a smoker. I call it a combined pulmonary fibrosis with emphysema. If I have a definite history that it's not a smoker and a middle-aged person, I have an occupational history of some paint exposure, etc., then I will go towards a occupational lung disease more so. So obviously, I mean, the interpretation definitely changes. The findings, like to call it reticulation, bronchiectasis, cystic air spaces, nodules, the findings don't change.
wonderfully said. I think, Nitin, would you like to add? I think
Very well
fantastic answer, and I think a very good question.
Perfect answer.
One more question has come, which I want to take, though I didn't want to take any more. Now, seriously, the last question. And this is between, for both of you all, I think, let Nitin answer first. So, Nitin, the question is that, how do you envision the future role of HRCT in the, how do you envision the future role of HRCT in the diagnosis of COPD and bronchiectasis with better communication between the pulmonologist and radiologist? Would it help or not required?
I think that's the future. I wouldn't stop only at HRCT. I would possibly even consider longitudinal data accumulation with MRI. Of course, it's not yet a tool which can be so easily administered to majority of our population because it's a very scary tool. Very frankly, I was scared shit both the times when I underwent MRIs. But well, if that issue gets taken care of, the kind of noises which are there around you can be taken care of, then I think it can be a wonderful tool. So even MRI, HRCT, I have no doubt about it. I think these both technologies, both imaging technologies put together or in isolation or, one tops the other, whatever happens in future, I don't know that. I am not a predictor on that scenario, but imaging is emerging as important tool to make early diagnosis, particularly in COPD. It will be definitely a game changer. In asthma, it will probably not be all that required so early in the game, but possibly over a period of time, we can develop better tools to do that. But early COPD diagnosis, I think definitely imaging is emerging as an important tool, as important as IOS, I would say.
Yes. So what do you want to, very well said, Nitin. So, and also adding on about the communication between pulmonologists and radiologists, Khushboo, is it going to make a difference?
No, can't agree more to it because I think we are moving, from an era like once upon a time there was a single general practitioner who used to do radiology and then diagnose and then treat. Then came an era where we all started specializing and we started moving on our own tracks where the entire medicine went in for a toss because a pulmonologist will diagnose something, the radiologist will write something else, and nothing used to fit. And I think again we are coming back to an era where we are all working together. So now 5 people combine to become one, that becomes a multidisciplinary team. And the more the communication is, the better it is for the patient.
Absolutely.
Wonderful. So we have about 18 questions still remaining, but I think we will probably write back the answers because it's already almost 10:25. I basically want to say a huge thank you to Dr. Nitin, Abhyankar, Dr. Khushboo, both of you all for the fantastic talks. Of course, Dr. Bhavin for awesome talk. And I want to really thank the two of you all for being there for the panel discussion and giving us fantastic state-of-the-art information. And I really like the discussion that both of you all were having and the answers which we have all the time in our minds. And while I'm talking, more and more questions are coming up. I don't know if to take them or not. Should we or should we wind up? Should I take 2-3 more questions?
No, I think wind up because I have to feed my dog. Sorry.
Okay, great. So, okay, I just want to take this question because it just came up right now. So, Khushboo, I'll just finish with this. So, Khushboo, Dr. Sujata Sarda is asking, many times radiologists mention cystic fibronodular lesions. What does this indicate?
We don't mention anything of this terminology.
No, so probably she might be facing, she might be having radiologists who write that. I like this question. That's the
Yeah,
reason.
Sujata comes from Latur, and it's a second tier city, so the radiology is different there as compared to radiology in Pune, and definitely different from what Khushboo is doing.
Yeah, so this, whatever people are known to me, I'm taking all the questions. I'm being partial, but it's so tempting. We know the doctor and we want to answer the question. So I so agree with Dr. Nitin, as Dr. Sujata is asking, because very often we see these reports, cystic fibronodular lesions. What does that mean? Does that mean bronchiectasis, sequelae of TB, or it's like something abnormal, but we don't know? Do a better quality CT.
No,
Or
ma'am. It just means that we need to see the CT scan to understand what this means. I mean, this is no specific terminology. It's a created
Yeah,
word.
it's a
So
created
I mean,
terminology, absolutely.
so
so
it
correct. So probably it needs to be described better. And yeah, I
maybe
think
seen better, ma'am, because it's
And
just
if needed, a better quality scan needs to be done again. If at
absolutely.
all, that's
Wonderful. So now I'm not going to look at only the question chat. So thank you so much, Khushboo and Nitin, for a fantastic panel discussion. A lot of questions that were asked were always in my mind also. And I just feel clinical history, spirometry, along with HRCT would really help us to provide personalized treatment to our patients. COPD not getting better, you did HRCT, there's bronchiectasis. Come on, add in some physiotherapy, add in hydration, partial drainage, and your patient will definitely do better. And he might be a recurrent exacerbator because of infection. Similarly, history wise, COPD, X-ray not so, chest X-ray not saying much. You do a CT and this is emphysema, so you know what you're really dealing with. Very often CPFE, do an HRCT and you actually pick up in an emphysema coexisting IPF. So I basically feel in today's day and age, as we know history is most important and we know that spirometry cannot be missed out in a patient of obstructive airway disease, I feel in patients of bronchiectasis doing an HRCT is a must. And all your patients of asthma and COPD who are not doing well despite adequate treatment, please do an HRCT because it will always contribute to adding on to some information that you didn't know, which will improve your patient care and will actually give personalized patient care. So with this, thank you so much again to Dr. Nitin, Abhyankar and Dr. Khushboo for giving out so much time. Thank you, Dr. Bhavin, Dr. Khushboo, and Dr. Nitin for the fantastic talks. I have them all, I heard them all, and I'm going to keep on referring to them whenever I have to give a talk on these subjects because they were just so perfect, the talks. A huge big thank you to GSK for being our academic partners. A huge thank you to Dr. Hardik, who has been trying his best to coordinate this wonderful session. Also, a big thank you to entire team GSK. And I would, of course, like to thank Indian Chess Society for this wonderful initiative of making sure that we are going ahead in our academic march of bringing in knowledge to everybody at the doorstep. Hardik, would you like to say something?
Yes, ma'am. Just a couple of minutes, but as in, I'm not that experienced, but believe me, this was one of the most amazing discussions I've seen, ma'am. And like I feel privileged to be part of such a amazing meeting. So first of all, ma'am, on behalf of GSK, I would like to express our sincere gratitude to you, ma'am, because I know all the efforts you have taken to make this meeting extremely successful. And yeah, it really seems that it has been extremely successful based on the audience participation. If we would have just taken all the questions, maybe 1 hour more also wouldn't have been enough, I feel.
Yeah.
And secondly, I also want to thank Dr. Pilania and Dr. Abhyankar for this amazing discussion, and also Dr. Bhavin Jankharia for an amazing talk that he gave. So, and basically, we are also incredibly grateful to Indian Chess Society for collaborating with us on this important topic of imaging and airway diseases. Basically, ICS's dedication to improving respiratory health in India is truly commendable, ma'am. And we deeply appreciate your partnership in fostering these discussions, ma'am. So hopefully we can have more such discussions in the future as well. And finally, a big thank you to all the esteemed doctors in the audience, because if not for them, we wouldn't have been having these discussions also, ma'am. So everybody's participations, thoughtful questions have really enriched this discussion. So last but not the least, this meeting has undoubtedly contributed significantly to advancing our collective understanding of airway diseases. And we at GSK as well as the ICS are committed to supporting medical advancements. And we believe such collaborations are extremely essential for better patient outcomes. So all in all, a very humble thank you to everybody, Dr. Abhyankar, Dr. Pilania, most importantly, Dr. Nene, Dr. Jankharia. Thank you from GSK. And
Thank you
have
so
a
much.
good night, everyone.
Right. And thank you, Dr. Samir and Dr. Yogesh Mane, Dr. Samir Arsule also, and the techno team for helping me join in. So thank you so much. Yes.
Yeah, thank you. Thank you so much, ma'am. There is a small poll at the end of the
Yes.
This thing.
Okay.
Thank you so much.
Ma'am, there's a small poll for the audience in the chat box. So kindly, I would request the audience to fill that poll and also the feedback for the webinar, ma'am.
Wonderful. Sure. So I'm sure, we have wonderful doctor friends who are doing brilliant work and who are always so proactive in learning new things. So a huge big thank you to each of you all for joining in. It'll be wonderful if you do the poll and give us a feedback. That'd be wonderful. So thank you. With this, I'd like to say goodbye to everybody. Thank you so much. Good night.
Goodbye. Good night. Good night.
Good night. Bye.
Bye.
Good night. Good night. Bye-bye.
Hi, Dr. Samir.
I think they're still relaying.
Okay.
Has the relay stopped? Abhijit?